So our speaker today, Dr. Stuart McClellan, is a teaching professor and a director of quality assurance in the Faculty of Nursing at the University of Alberta, and a nurse practitioner with Alberta Health Services Correctional Health Care. His scholarship sits at the intersection of correctional healthcare, relational ethics, and clinician formation. His work examines subjective experiences of pain and embodied distress among people who are incarcerated, the ethics of care in complex correctional practice contexts, and how therapeutic relationships are built in settings shaped by mistrust. More recently, has expanded his program of inquiry to professional identity formation among correctional nurses and other health professionals, with particular attention to writing as an epistemic practice and a mode of inquiry that supports reflection, self-revision, and identity reformation over time. Without further ado, I pass it on to you. Thank you again for being here.
Yes, thank you, Michael, for that kind introduction. So today I'm doing a quick kind of discussion here about relational ethics and asociality. And I just want to kind of preface this in some ways that this is more about a problem around or a potential problem of formation rather than an issue around manners. And um, I began thinking about this in dwelling more about how correctional nurses form or reform an identity as correctional nurses. So, what is the professional identity of correctional nurses? What is the professional identity of nurses or correctional physicians or whatnot? And then how that links to professional identity formation in general. A lot of work's been done both in medicine and nursing on that, so I'm relying on some of that body of knowledge and literature. Um, but we do know that professional identity formation, starts before entering into a professional program, before entering into medicine or nursing or social work or whatever other health profession students enter into. So there's an element of selection, looking at potential criteria for admissibility, and then potentially some of the emerging problems that we are encountering with, an increased um, presence of, artificial intelligence and technology in our world. So the concern is not simply whether learners interact frequently, or whether we or the learners prefer digital communication or virtual communication platforms. The concern is whether the habits of kind of that reciprocal, accountable engagement with other humans are becoming thinner as learners enter the professional educational setting. So I said earlier that this is an emerging type of research area in general, not just in my own thinking, but I don't think there's a sufficient evidence base to make claims per se that the youth social trends, and the connectedness with social media is creating, in and itself an asociality that is contributing directly to unsafe care. But it the aim of what I'm trying to do here is to offer some kind of anticipatory type of guidance in a sense, to potentially help shape how we can inform nursing and medicine and other health education programs, to more intentionally consider how engagement and authentic engagement can play a role and should play a role in health education. So, I say if authentic engagement is central to relational ethics, and I think it is, then diminished engagement may become a very important problem for future health professional education and health practice and regulation bodies, in the future. Um, so moving forward, I think, like I said, why this matters, engagement isn't just a soft add-on. It's not a nice thing. It's not a cosmetic feature. And it's actually instrumental to how we form relationships with each other in general, and then how we form relationships with patients. It creates the space for ethics to exist. It creates a space for care to occur. In relational ethics, as I said earlier, authentic engagement is part of what makes care ethical. So if you're authentically engaged, interested in the person and their stories, that is essentially a very core component of ethical care. So of course there's other features as well, but there's a hinged kind of component on ethical engagement. So the core argument is that if ethical or authentic engagement weakens, there is a risk not only for poor bedside manner, but also general weaker attentiveness to clinical issues, poor interpretation of clinical findings, and a thinning responsibility or thinning sense of responsibility in care settings. We do know that this is a problem in general, um, but we also know that healthcare is about responsibility. In fact, most responsible healthcare provider, most responsible provider, is embedded in the titles or kind of the lead characteristics of some roles in our health settings. So again, this is about conditions for formation that allows for authentic engagement to occur. Um, we can get to a point where learners may become very good at looking engaged. We can cause or create, simulated experiences where people become really practiced at speaking empathetically, navigating through assessments. But the question is, and should always be at the forefront of educators and clinicians, kind of the guards, of the professions, if you would, is whether those performances are um, reflective of the relational and reciprocal relational presence, if they have a sense of curiosity and commitment to other people, and again, if that sense of accountability is present. So, just to be clear, this is not about being anti-digital. I think, artificial intelligence and various forms of technology and technological advancement is is here. I think it's going to have significant positive impacts on research and how we conceptualize care and how we can potentially improve care outcomes for patients. I also think in the educational world, using various types of technologies and generative, ways of interrogating kind of a database of knowledge to come up with some information and data that could be, used and interpreted by the learner. I think that's all very, very good, right? But we also need to be very concerned about how individuals not only engage with with this type of content or with specific sectors of content. So, the idea of your for you page in your social media, you're very much kind of pigeonholed a priori into kind of an type of belief system. And how can that technology be used to help improve, the relationships and the relational capacity between person and person, as opposed to, a kind of a relationship in essence with the technology or people playing an actor on the other end of technology. Again, this isn't a blanket indictment on youth. I don't want to get into pathologizing an entire generation. In fact, arguably, there are asocial asociology, is evident in all generations, and we see it across kind of all ages and stages of life. In many ways. I think it's also important to disambiguate this from antisocial type of behaviors. And we'll hear people say that they're antisocial or describe themselves as antisocial, or maybe describe another person as antisocial, and meaning very literally kind of not engaged in society, or having difficulties engaging with other humans. And that term antisocial is also a very loaded term from a diagnostic perspective for personality, and that term is more interpreted, especially in the health settings, as being against kind of the fabric of society. And by the way, this is kind of where the forensic component comes into play. Is, you know, people would, my ears would perk up when they would talk about antisocial, or this person's antisocial, or I'm antisocial. And I'm thinking, I work with, a lot of antisocial individuals on a fairly routine basis. And, what you're talking about isn't antisocial in that diagnostic way. What you're talking about is more about this asociality and kind of a lack of skill, or less practiced skill in being sociable in a sustained and comfortable way with other individuals. And then it's not only a communication skills issue. So we do have, labs where we teach things like, how to ask a probing question, or how you can be empathetic, or what's an open question or closed question, and these sort of things. I think those are instrumental to basic approaches to communication. Writing becomes very instrumental because, writing gives you a structure of how to communicate arguments or explanations and whatnot, which are really quite instrumental in any type of human-to-human interaction, or care reaction interaction. And but more importantly, the communication component is also significantly important because engagement helps shape kind of how you are being able to attend or interpret, some of that nonverbal cueing from from another individual. It shapes your overall attentiveness and interest in individuals. It also potentially impacts things like trust, and again, the responsibility and care. Um, so, here's some of the signals that are a little bit concerning, and this is driving kind of a area of research in CIHR around asociality. And right now, I mean, certainly it's not, I always emphasize signals, are not diagnoses, but they tell us that potentially something is potentially emerging, right? We look at rates of loneliness. Worldwide loneliness rates are very, very high. So, but 1 in 6 worldwide experience loneliness. By the way, this here loneliness indice is often important in health because loneliness and things like smoking have the same uh, risk factors, or relative risk for things like heart attack and stroke and whatnot. Apparently, adolescent and young adults, a little bit more than the general population at 1 in 5. Um, and, looking at 39%, only 30% of teens say smartphones help youth learn good social skills. And then 39% say being without their phone makes them feel lonely at least sometimes. So, better than almost 40% of the population, if you have no phone, they're actually feeling lonely, right? If I don't have a phone, I'm feeling panicked. I don't necessarily feel lonely, but I feel panicked. But this here is a true loneliness when they're actually measuring this out. So again, this does not necessarily describe what's going to happen, or describe the health professions themselves. But I think if we're drawing in students from, this kind of population base, it may indicate that we are going to have some issues in formed, engaged relationships as students enter into the professions, which may impact professional identity formation. So let's just kind of take a look through this a little bit. Um, so clinical education can reward visible participation before it cultivates kind of authentic engagement. And we often see this, turning up is important. You get rewarded for, turning up. If you miss a class, you get docked, right? Just by turning up and sitting in a room, doesn't necessarily mean that you're doing anything more beyond being physically present, right? Engaged interaction means that you're actually able to be fluent within a context, that your role is appropriate, and that you at least look attentive. You may not be truly attentive. You may not really truly be able to pick up on subtle cues. But this is kind of a fake it, This is actors do this really well. So if you're watching, Grey's Anatomy or something like that, I guess, they can fake the role really well. But, I certainly wouldn't want to have them do any real medicine. Practice medicine in any real way, set up a clinic or anything to that effect, where the authentic engagement really takes it a little bit of a step further. It involves this res, reciprocal, responsible, or responsiveness and accountability, and it really remains open to what other person is actually disclosing and how that may alter the clinician and the clinical encounter itself. So why engagement is ethical, not optional. Here is kind of that relational ethics, framework, if you will. I hate calling it a framework, but for the lack of a better term, I will. Um, it shapes kind of the moral quality of care within relationships, not only within kind of isolated acts. So it takes kind of that subjective ethics, meta-ethic perspective. Engagement is one of ethic, one kind of domains, that we have within kind of this understanding of relational ethics. But it actually is an important hinge that kind of keeps all other actions from being just merely procedural. Um, taking a blood pressure, but being able to recognize not only why you're taking a blood pressure, but actually caring if the blood pressure is high or low or accurate, if the blood pressure is causing injury, it has the potential of causing injury, if there's other components that need to be attended to. So looking at authentic engagement, what does this looks like? Being authentically engaged improves attentiveness, like I said, so notices what is said, what is unsaid, and what is potentially difficult to say. Creates conditions for disclosure, honesty, and repair. Also helps develop a shared understanding, builds meaning with patients, families, colleagues, rather than just kind of extracting data and moving forward robotically. And it also, importantly, attends to this idea of accountable responsiveness. So it responds in ways that are answerable to other persons and to the situation. So, um, you know, I think one of the one of the things that we are seeing now is if we were to critique some elements of the health system, I mean, we're all very, very busy doing a lot of really, really important things, but we can all sometimes recognize where individuals have not necessarily been accountable in the ways that they should have been, right? So if they would have asked a simple question, it may have prevented further hospitalizations or repeat visit to the emergency department. If they engaged the patient a little bit differently, care outcomes may have been potentially improved. So I think if we are honest with ourselves and reflect on some of our own experiences, we could probably recognize that in others and probably even in ourselves. So these are some of the risks of when engagement becomes thin. So it kind of looks like kind of an engaged interaction. It can complete the task. It looks appropriate. So it has the appearance. It has kind of that cosmetic effect of looking complete. So a form is completed. Um, but authentic engagement is truly meeting the person in and through the task, right? So it's being truly attentive, listening. Um, you extract the needed facts, right? But the authentic engagement, it moves beyond just holding a hand and using, some of those prompts, basic prompts. Tell me more. So from what I'm hearing, those basic communication skills, to really being attending, open to looking at meaning and context, and potentially allowing for a space for things that are difficult to say to be said. Um, that also goes with clinical trust. And uncertainty, hide it or kind of smooth it over. You just kind of push it aside. It makes you feel uncomfortable. So this is like the sex talk. Had a student who had a patient with urinary symptoms and was in their mid 70s, and and she's saying, well, we did a screen for infection for urinary tract infections, and I said, well, what about STIs, right? And you can see that was a very uncomfortable question. How could she ask that question? Was this person even having sexual relationships with another person? In that made them uncomfortable. It maybe would make this patient uncomfortable. So in a way to avoid, or overcome that uncertainty, it just kind of, moved it aside. I suppose it's a form of avoidance. So here, an authentic engagement, it would be to name it, to say, I don't know what's going on, but I know this might feel a little bit awkward, or I'm not sure how you feel about this, but I need to ask, I need to know, if you have a possibility of having an STI, are you sexually active? Do you think you have chlamydia or gonorrhea? These sort of things, and then at least keep it open for a question to be answerable, or for a situation to be addressable. The ethical risk uh, in a kind of a thinning, and even like an engaged interaction that is thin, it can look like it's complete, but and so it can be measured as complete, but it actually is very much incomplete, and doesn't have a way of really repairing relationships, guiding judgment in a nuanced way, or creating action that would be clinically nuanced to an individual. So this is the identity formation piece. So, identity formation. So PIF, this is another one, PIF, PIF, professional identity formation. F is formation, is formed through repeated relationships, reward, and expectations, not only through formal curriculum. So, how we get into the program. So there's potentially some admission information here that would be important. So as the society evolves, we may need to be looking at as an admission criteria coming into the program, habits around attention, reciprocity, avoidance, engagement. Avoidance and engagement would be kind of counter to one another. Learning norms, right? What is rewarded, what is modeled, what is ignored. This is something that's you know that that we've all experienced in many different ways, and students are very, very attentive to this. And as instructors, and many of us serve as instructors in different programs, either with didactic courses, formal professor roles, or in clinical contexts, or maybe you're a student who is helping another person learn, but you become cognitively aware of what the other person wants, right? Um, in some of the work I do around writing and why we write, students get really anxious around writing, not necessarily because writing is difficult, but they they want to be able to predict what the instructor wants them to write. So it's not a writing activity for their own learning. It's writing, or it's an activity, a writing activity to please their professor, right? And that becomes a very stressful act. And I think this is also then modeled and kind of reinforced in how we mark some of these assignments. So, if we look strictly on appearance, right? Kind of that engaged interaction. If we say we look at form and format, right? So this would be things like you can write a perfectly good looking paper, and it has all the periods and commas and spaces and in the right areas. It has in-text citations. The citations are correct. It also potentially has excellent grammar, APA or MLA or Chicago, style is perfectly intact. So it looks like a perfect paper, but it may actually do nothing to advance one's learning. It may actually do nothing to advance one's learning, or to advance knowledge development. If you're a scholar, at a master's, you're developing new knowledge and these sort of things. So coming back here, this is where learning becomes really important. What are we actually teaching? Are we teaching students to be anal retentive, or are we actually teaching students to use tools for learning to actually learn? This becomes really important because we have students who come in with a partially formed, with an identity formed, and people do have identities, and now we're helping them shape a professional identity. So it's through these learning activities and these modeling where we're eventually going to get the student moving towards the development of professional identity. So as we shape that, in whatever clinical learning situation or, academic, didactic learning situation, as professionals, as teachers, we need to be aware, what are we actually modeling? What are we actually teaching? Are we teaching students to be anal retentive, to be thin, to be inauthentic, or to actually be engaged, to make mistakes, to celebrate, an error that they've learned from, to celebrate, deep cognitive and metacognitive learning, and to what end, right? That's where your professional identity comes from, and this professional identity is formed, and probably I would argue reformed as you experience practice, reflect on practice, and become stronger and stronger in clinicians, and that in turn influences clinical presence. Okay. Um, here, these are some kind of examples of where thin engagement kind of, can matter, right? So again, history, consent, handover, supervision, team conflict, family talks. These are all areas that are kind of either transitions of care or moments of kind of high stakes or uncertainty. Communication becomes really important, but relying solely on kind of these communication tasks that you may learn in a lab somewhere are often insufficient because it doesn't go deeper and understand kind of the ethical elements that are embedded within each of these types of situations, right? So, taking a history, but not being sufficiently attentive such that things are missed or not asked or opportunity isn't given appropriately for things to be asked. Handover, right? What is withheld? Is it safe to say that you didn't do something to the next shift or you're going to be punished, et cetera, et cetera. So here, are some of the kind of the kind of where we could start potentially looking at some of the relationships. These are again, I just want to, they're not proven causal change. They're just kind of they're hypothetical areas. They're kind of early developed ideas where relational thinning may impact practice consequences. So missing cues and thin curiosity can contribute to weaker judgment and planning, avoidant dialogue, brittle decisions, unsafe handover, performative empathy. So not really just pretending like you care, like pretending like you're in it. People pick up on that pretty quickly. You're going to end up with a fairly significantly eroded trust. People will identify that as fake, feeling comfortable, and that often will contribute to things like lower disclosure, weaker collaboration. So this impacts not only patient care but professional relationships, and then moral distancing. Right? This is a thin sense of responsibility. So this is not my problem, not my monkeys, not my circus, or not my circus, not my monkeys, however that saying goes. And this here can actually normalize kind of brittle and unsafe care. It can normalize um, uh, and isolate patients who potentially need more engaged interactions as a way to be safe in communities. So again, just kind of uh, looks technically competent, might meet all the kind of the check marks, right? A learner takes a careful history, then the patient answers briefly, hesitates when asked about home supports, and then later tells another nurse, I did not think he really wanted to know, right? Um, Thank goodness that the patient said I did not think he really wanted to know because, hopefully a more responsive nurse would be able to say, okay, well, what was it that you wanted to know, right? Um, this here can delay care. Was the gap skill, time, curiosity, or accountability? What signal to the patient that disclosure was not really welcome? Would engagement, authentic engagement, have changed anything here? So while it may be technically, everything looked okay, there's still some vulnerability here that may have happened uh, to the uh, to the learned observer in many ways. Professionalism without presence. This is getting at this idea in this case here, student presents confidently, asks clarifying questions, avoids disagreements, is just the perfect student in the, doesn't, ruffle feathers during handover. Key uncertainty is left unspoken because the student does not want to be unsure or uneasy or stupid, however you want to talk about it. And what are the effects of this, right? What are the effects of this? When does role performance become ethically unsafe? right? What educational signals taught this learner to hide this type of uncertainty, and how might supervision make uh, a different response possible? This, by the way, I think if we actually were really honest with ourselves, this isn't a new problem. This is kind of a perennial problem that may just be worsened. I was at a conference, and we were talking about nurses and other professionals who have sex with their patients, and that, because as one does at conferences, this is, and it was in a forensic context, and issues with you know boundaries and these sort of things. And one of the speakers was saying that having kind of that introspection and that insight into identifying when you've overstepped a boundary, and not only when you've overstepped a boundary, but how to retreat from that boundary violation or boundary crossing violation, and who to talk to before you get yourself into a situation where you're being significantly manipulated, and you make kind of increasingly poor decisions, or you actually have the ability to insight that. And one of the managers said, well, my staff are really open and they talk to me all the time, and they can tell me anything. And I'm thinking to myself, really, can they actually tell you anything? If they were, having, fairly unpure thoughts about a patient, and is that something that would be safe to talk about? Even if the having the talk about it, would potentially create a situation where something could be put in place where you could be, more attentive to the needs of that staff member, make sure that that they're not looked after, or you have some type of um, um, uh, intervention where you can kind of prevent boundary crossings in general. And this isn't, we're not talking about, as I'm talking about this, and I'm not sure of the entire audience, but we're not talking about an abnormally perverted clinician. We're potentially talking about just kind of normal sexual responses, that can happen, from person to person. And having someone to be able to talk to, and you can trust, can sometimes help, thwart you making a bad decision, right? Kind of brings you back to the ground. So, this is not about, perversions or anything like that. It's about actually having kind of really deep, authentic relationships. But the point, I was making here, before kind of getting a little bit distracted, I suppose, was that the manager, was quite convinced that the staff that reported to her would tell her things like this, that this was not going to be an issue. And, there were two staff members, sitting there behind her, and very evident that they would not tell her, what was the case, which leads to kind of a disconcordance between the manager's own kind of vision and thought about, what their employees do. And then it also creates an issue around safety, right? Around safety. Anyways, so are you an open clinician? How are you going to respond to situations that may be uncomfortable? Do we have kind of models of clinical supervision? How can we foster that in both, the education and then onward, right? So this polished neutrality and confident kind of delivery can essentially conceal relational withdrawal from uncertainty and responsibility. And I think we see this all the time. Um, it becomes also socially performative. We see this in it's kind of like people who become really well practiced in different and more contemporary social etiquettes. So it's also seen individuals who, a good example, will give a land acknowledgement but it's more of a checkbox, disengaged land acknowledgement. And they don't, the person actually doesn't believe in it, and they're probably, extraordinarily racist, right? But, if you look at kind of their way of expressing themselves, they seem extraordinarily polished, very confident, meticulous in their appearance, their social appearance in many ways. But it beyond that kind of veil of if you scratch the surface a little bit, you can really see that there's problems that are significantly more fragile that need to be attended to. Um, some of the usual fixes that we have been running to: communication skills, communication skills, communication skills. These are can be helpful. Certainly, if you have ineffective communication skills to begin with, that is a good starting point. But I think the main message here would be to ensure that you go beyond just practicing communication skills and that you actually work to socially engage through using effective communication skills. Um, Professionalism. It's more than just an accessory. It's more than just kind of a polished exterior. There's a genuineness that needs to be present in professionalism. And then, also this idea of wellness. Certainly, we want students to be well and clinicians to be well. Um, but, there's it can sometimes create supports to help distressed individuals while potentially overlooking relational and cultural conditions that kind of shape how people learn to meet other people and learn to uh, you know to interact more socially in different contexts. Um, so here's some of the early educational responses. I think we need to name it. We need to distinguish uh, authentic engagement from just issues around or engagement for the purpose of fluency and compliance. Compliant engagement, I suppose. Rehearse it. So we need to use ambiguity, vulnerability, and repair in simulation. Simulation. It needs to be more than just performative. Um, it needs to truly be learning. Observe it. So we need to make sure that we're mentoring, uh, uh, that we are posturing and creating places for curiosity to exist in clinical environments, staying with discomfort as opposed to avoiding it. Discomfort isn't bad, where, this idea of being uncomfortable or feeling, a little bit of discomfort should be avoidance. This kind of a avoidant, discomfort avoidant phenomena needs to be seriously addressed and looked at. Reflecting, using narratives, debriefs, and ethics reflections to make meaning. Um, I'm increasingly challenged by this for the reason that I spoke about earlier. Often, in school, we get students to reflect, and what I'm finding is when the reflection is written and submitted for marking, it's critiqued. Now, I think critiquing a reflection and pushing students towards, a deeper reflection is one thing. But again, it can become performative, especially if the instructor um, makes it clear that they want you to be reflecting in a certain way on a certain topic. So it becomes a lot of work without very significant yield. With some technology, AI in particular, we could actually leverage on this. We have to be careful with kind of mirroring that can happen and whatnot, that from the AI models. But it could be a safer place for students to actually use for initial reflection, and then maybe the role, bring it back to the instructors to say, this is what I've learned through the process of reflection. So it creates a little bit of distance. Ironically, creates distance between the instructor and students so that they can become more engaged with themselves and their own understanding of themselves as learners or as individuals you want to use it yourself. And then assess it, right? Um, Looking at, yeah, it looks good. So it's like walking into a room, everything looks beautiful, the furnishings are really good, but if you tug on the curtain, does the whole curtain rod fall down? Because, it's just attached to wood that's rotten and plastic nails that won't do the job. What leaders can do now. Here are some of the ways that I think that we can help foster this beyond kind of the clinical, beyond the clinical academies, beyond the academic institutions, is beginning to attend to relational thinning as part of the ethical landscape. For difficult cases to say, like, what is the relationship looking like here? Is there relation no thinning? Is there true authentic engagement? Similarly, naming ethical failures or engagement failures explicitly as part of kind of that ethical analysis in conjunction with things like what is the ethical conflict or what are the communication errors? What are some of the authentic engagement errors? Includes harms of unskilled engagement, right? So, what were the harmful helpers doing, right? Think of Gerald Egan's, Skilled Helper book, his communications book. The name almost promises that there's an unskilled helper in many ways. Um, and then looking at faculty and preceptor development, kind of help supervisors recognize polished disengagement and coach relational presence. So, how can we move from this? You look visibly pleasing, you have all your everything looks good on the outside, but how can we make sure that it's tested so that the outside matches the inside? So that we're really truly authentic. Um, there's the next question. So questions before entering the field. Again, we're not here to kind of settle anything, to settle measurement, or to prescribe kind of a single curricular model, but it's really again just to kind of step back and say, we know a lot about engagement. So what is it? And how can we use this in a time when engagement is potentially thinning due to kind of some ongoing relational challenges posed by kind of the current technological landscape? So, what should count as evidence of authentic engagement? We know that appearance is a misleading calculator of that. So what should count? How can we teach and assess authentic engagement without simply rewarding performance? I don't want students to just mimic me. I don't want students to write to, a paper to a rubric or answer test questions 100% of the time just to make me happy. I want students to truly be learning to become professionals. So in that way, that pleases me kind of at the macroscopic level as an instructor. But how can we kind of avoid, rewarding kind of incrementally for this here? Basically, like you get an extra point for you if you wear relational earrings or something to that. If you have a relationally full head of hair, it needs to move beyond that type of reward. And what should ethicists and scholars notice before thin engagement becomes normalized? How can we prevent the normalization of thin behaviors and thinning engagement? So kind of in closing here, I've very kind of, felt repetitive in some ways that hopefully it was useful. Um, but, if we were to think that authentic engagement is ethically constitutive of care. So, if authentic engagement is an ethical requirement of care, then cultivating is not just simply enrichment work. This is the core work of what we need to do in ethics, in our professional ethics, and in our professions. So the future problem is not only what learners know or say, but how they learn to meet other humans and how things are said and asked. Um, so I think I'll leave it for there, if there's any questions.